Hi, I'd like to welcome everyone to my case report. My name is Matt Thomas. I did this case report in collaboration with Dr. Karthik Anath. I'd like to thank him for his involvement and his help. The title of it is called Time to Relax with a Myosin Inhibitor, Dawn of Mechanistic Therapy in Hypertrophic Cardiomyopathy. Until the development of myosin kinase inhibitors, there has been no medicinal treatment that has targeted the pathophysiology of obstructive hypertrophic cardiomyopathy. The Explorer-HCM trial was the first myosin kinase inhibitor trial, and it showed that Mavacamten in specific can be safe, improve the patient functional status, and reduce left ventricular outflow tract gradients. The overall goal of this case is to demonstrate the efficacy, safety, and appropriate use of Mavacamten in clinical practice. Over to the right here, you can see a picture of the pathophysiology involved in hypertrophic cardiomyopathy and the excessive actin-myosin cross-bridging that occurs, resulting in hypercontractility, thus hypertrophy, and in some cases obstruction. Mavacamten works directly in that pathophysiology to reduce the actin-myosin excessive cross-bridging, therefore attenuating the hypercontractility and reducing the hypertrophy and the obstruction that can result. Our case report begins with a patient, Miss G, who is a 71-year-old female with a past medical history of obstructive hypertrophic cardiomyopathy, chronic obstructive pulmonary disease, transient ischemic attack, and hypertension, who presented to an outpatient clinic with progressive dyspnea on exertion. A transthoracic echocardiogram showed a left ventricular ejection fraction of 78%, mild concentric hypertrophy of the intraventricular septum, thickening of the mitral chordal subvalvular apparatus, systolic anterior motion of the anterior mitral leaflet, a peak obstructive left ventricular outflow tract gradient of 108 millimeters of mercury with Valsalva, and a resting gradient of 27 millimeters of mercury. She had been on a max tolerated beta blocker without improvement in her dyspnea, and she had worsening fatigue as we escalated the beta blocker doses. We therefore decided to start her on Mavacamten at 5 milligrams daily, and at the same time the beta blocker dose was reduced because it was contributing to her fatigue. The first of a every 3-month monitoring transthoracic echocardiogram showed a reduction of the dynamic gradient from 108 millimeters of mercury to 14 millimeters of mercury. There was resolution of the systolic anterior motion of the anterior mitral leaflet, and at the same time, the left ventricular ejection fraction dropped from 78% to 70%. At this time, the Mavacamten dose was reduced from 5 milligrams to 2.5 milligrams, which was the maintenance dose of the medication. The left ventricular outflow tract gradient remained less than 20 millimeters of mercury. The duration of the therapy and the left ventricular ejection fraction remained at 70% and did not drop any farther. The dyspnea on exertion significantly improved, and the NYHA functional class improved from a 3 to a 2. The patient was able to attend a cruise with very little limiting symptoms, which was a remarkable difference than prior to starting the medication, and allowed her to ultimately start living a more functional and enjoyable life. So this case report mirrors the findings of the Explorer-HCM trial, which showed reduction of the left ventricular outflow tract gradients, improvement in patient functional status, and a mild reduction of the left ventricular ejection fraction of about 4% on average. It also highlights how to safely and effectively manage Mavacamten in clinical practice. Specifically, it demonstrates the FDA-mandated REMS program-based regimen to safely adjust and monitor Mavacamten in order to prevent excessive reduction in cardiac function while efficiently treating the cardiomyopathy. Mavacamten shows promise in providing a safe and effective non-invasive alternative treatment to procedures such as myomectomy or alcohol septal ablation in obstructive hypertrophic cardiomyopathy, which are associated with a significant amount of morbidity. There are limitations to Mavacamten use and this case report overall. Specifically, there needs to be access to monitoring LV function and that is required by the FDA by use because it is associated with a drop of left ventricular ejection fraction of about 4% on average. If you do have reduction that is out of proportion of the average 4%, Explore-HCM trial did show that with discontinuation of use, it was able to recover. Furthermore, the use of Mavacamten in non-obstructive hypertrophic cardiomyopathy is currently being investigated and it's not validated. So right now, Mavacamten is specifically validated and used for obstructive hypertrophic cardiomyopathy, and in the Explore-HCM trial, they looked at LV outflow tract gradients of greater than 50 millimeters of mercury. There are financial constraints associated with the medication, and the overall availability of the medication is also a constraint, but hopefully over time these will improve. And in conclusion, this case demonstrates the appropriate monitoring, and it shows that Mavacamten can be realistic, safe, and an effective treatment in obstructive hypertrophic cardiomyopathy. I'd like to thank you all for taking the time to listen, and thank you.